Good afternoon. Thank you all for coming to the last Faculty of Health Sciences seminar of this semester. There will be no seminars over the summer period. I know it's reading period, so if there are any students now, thank you for coming to attend this seminar. We will have, of course, exciting and interesting seminars starting the next semester. It's with pleasure that I will introduce Dr. John Lavis. This is a seminar that's organized in collaboration with the Knowledge to Policy Center. Dr. Lavis is visiting Lebanon and has been participating and giving a workshop on evidence-informed policy in past few days for researchers. Dr. Lavis is the director of the McMaster Health Forum. He's an associate director of the Center for Health Economics and Policy Analysis, professor in the Department of Clinical Epidemiology and Biostatistics, and associate member of the Department of Political Science at McMaster University. He will be presenting on what have we learned about how to support evidence-informed policy making. I also want to add that Dr. Fadi Jardali, who is the director of the Center of Knowledge to Policy, actually is apologizing because we are having currently at this moment a workshop in College Hall with media people on how to use evidence to inform policy. So he's giving a workshop. So Dr. Lavis.
Thank you very much. Thanks. It's like when I give undergraduate classes, I have 50 wires attached, so I might attach myself to something as I'm talking. I also tend to move around, so just be alerted that if you're on Facebook, at one point they might be behind you, so I'll be able to see them. Don't hesitate to interrupt me as I go along, but there's going to be lots of time for question at the end, so I'm probably going to talk for about half the time, but I'm happy to take questions in the middle of it, and then you'll have half an hour for questions at the end. So some conflicts of interest. I'm going to be giving a lot of examples when I talk, and I'm involved in many of them. I play different roles, and so I just wanted to flag that at the beginning. I'm also going to sometimes be talking about the Knowledge Policy Center, and I'll be honest that I'm a big fan of it and what it's trying to achieve, so I put that on the conflict of interest statement as well. So overview, I'm going to talk about why do we maybe want to think about doing this type of thing, and how would we know it if it existed. I'm going to mostly, though, spend time talking about promising practices and what the research evidence is currently telling us about those practices. I'm also going to talk briefly, if I have time, about what's needed to do the work, but to do that I have to walk you through some of the things that we need to do in this area, which is know how to clarify a problem, know how to frame options, and know how to identify implementation considerations based on the best available evidence. And then I'm going to put 3 top priorities for action at the end, and I'm going to use that as a jumping off point for a conversation with you. I think at least one of them might be a little bit controversial for AUB, so we'll see. You'll have those at the end to jumpstart the conversation. So one question for you is, which would be considered the most compelling reason for investing in evidence-informed policymaking in this country? Would it be that it might give us a better process or a more efficient process when we make big decisions about the healthcare system? Would it be that we end up with better decisions in the long run, or maybe more acceptance of those decisions? Would it be that we could better communicate decisions and maybe save some politicians a lot of embarrassment? So increasingly we're seeing politicians held to account in many countries around the world when they make statements that are clearly not based on any research evidence. Or would it be better outcomes and better value for money? So there's a few of you who've been in the workshop for the last few days. At that workshop, more people argued for the last one, better outcomes, better value for money. So we're doing this because we want to have a bigger impact on people's lives, and we want to do that in the most efficient way possible. So any dissenting voices that maybe in Lebanon, it's that last argument that's the most compelling? Okay. All of them. You want all of them? Okay. All right. Usually people are a bit more focused on the outcomes, but I think they're all true. You think outcomes is most important? Okay. So when I talk about using research evidence in policymaking, it's important to know that whether we like it or not, politicians are going to make decisions, and then after the fact, they're going to try and find research evidence to back up the decision that they've made already. And that's just a reality of life in a political system. But what we're trying for is to support them using research instrumentally. They're trying to figure out, should we be putting in place this very specific new policy that could have certain types of effects, or we're trying to help them think about problems or options differently. So many ways to think through a health human resource crisis, many ways to think through options for addressing the refugee crisis with Syrian refugees coming into the country, and research can help people to think differently about both problems and options. This is the definition of evidence-informed policymaking that we use. So I get into trouble with my colleagues for this part of it, best available evidence in the time available. But the reality is that policymakers sometimes need to make decisions in hours and days, and sometimes they have a few weeks, and very rarely they might have a few months. And if we can't get the evidence to them in that time, then we have no prospect for it being used. So it's using the best available data and research evidence, and very importantly, systematically and transparently. And you can be systematic in 5 minutes. You can be systematic in 5 weeks. Obviously, what's being systematic means looks different if it's 5 minutes versus 5 weeks. And we need to be doing it for the agenda setting stage. So of all the issues we could be focusing on in Lebanon right now in the health system, are we focusing on the right ones? And when people are lobbying for their pet issue to get on the agenda, are they backing that up based on strong evidence? And understanding a problem and its causes is an area where research can play a big role. We also want evidence about policy and program development, so which approach should we use to address a particular problem? And we want evidence to help us on the implementation side. You can have a lovely policy on the books, a lovely program, and it's not reaching the people who it's meant to actually serve. So research evidence needs to be involved in all of these. My clinical epidemiology colleagues are very, very focused on this stage when they think about clinical decision making, but many people in the policy world would argue 90% of politics is arguing about the problem and its causes, and research evidence can help us to get that right. Best available evidence means highest quality, most locally applicable. So locally applicable evidence for Lebanon might look very different from locally applicable evidence for Canada or for Burkina Faso. But we're trying for the evidence that makes sense for a given health system. And it's ideally synthesized research evidence. And here at AUB you have SPARC now, which is doing systematic reviews on some of the big issues that the country is confronting. Hugely helpful to be able to draw on that synthesized evidence. So any questions about that definition? As I mentioned, some of my colleagues give me a rough time for best evidence in the time available, but for me that's absolutely critical. If we can't help people in short time periods, then we're going to lose the battle of seeing evidence used. Questions or comments about that?
Well, I guess,
Yep.
yeah, this is the nature of evidence. So, I mean, I think we're assuming that it will all the same definition of evidence. So maybe you could spend a little time looking at what we mean by evidence.
Sure. Well, I'll come to it a little bit later, but I mean many types of evidence. I mean qualitative research that helps us understand how patients view and experience a problem. I mean evidence about the effectiveness of 2 different options, tons of different types of evidence. But I do mean scientific evidence that's been produced through a systematic and replicable process and has been transparently reported. So I'm talking scientific evidence. That's not to say that there's many other types of evidence that aren't essential. So for the stakeholder dialogues that we organize, tacit knowledge, people's real-world understanding of how the system works is absolutely central as an input to the process. And that's a type of evidence. But I'm talking here about how to use research evidence as one input to the process. So these are some of the challenges that policymakers and stakeholders bring up when we say to them, why is this stuff so hard? So they say, well, it's hard because research evidence competes with many other factors. It's not valued, it's not relevant, it's not easy to use. I wish I could tell you that as my colleagues in the world of informing clinical practice with evidence, that we had hundreds of systematic reviews showing the effectiveness of interventions to address these challenges. We don't have that. We have 2 systematic reviews, both of which contain 1 study each that look at the effectiveness of interventions. What we have instead is a systematic review of every study that exists out there that's about the factors that influence the use of research in policymaking. And they come from all over the world. They come from this region, they come from Africa, they come from Latin America, they come from North America. And the factors that come out time and time again are timeliness, being able to get the right evidence to the right people at the right time, and interactions, the chance to talk through what does the evidence mean in our context. But what I'm going to be describing in the coming slides are things that are highly promising. We have lots of evidence that they're highly appreciated, that they translate into greater intentions to act on the evidence, but we have yet to evaluate them rigorously in terms of their effectiveness. And that's a big part of the agenda in the coming decade. So the first challenge, research competes with many other factors. I guess my view is this is just the reality in a democracy. So policymakers, politicians are working under institutional constraints about what the Constitution, for example, says they can and can't do. They're dealing with interest group pressure. They're dealing with values. They're dealing with tacit knowledge. They're dealing with their own and others' real-world views and experiences. They're affected by these things that spill over into healthcare, civil wars in adjacent countries, recessions, that type of thing. Some people think we can improve the policymaking process. I can't imagine the little tail of health wagging the dog of the entire political system, but I suppose it could happen. The only time we see this happen is for routinizable decisions like technologies. So in some countries, we've pulled the decision about funding and not funding technologies out of the political fray and made it much more technical. The United Kingdom's National Institute for Health and Care Excellence would be an example of that. Many countries have it. We have it to some extent in Canada, but for all the other decisions about health systems, that would not be the case. So this for me is background, critically important. The reality is we're dealing with a political system. We can do things about the extent to which research evidence isn't valued. So as with every workshop we run, it doesn't matter whether we're in the poorest African country or the richest Latin American country. Whenever we start workshops, people say, oh, but our country's different. And our workshop 2 days ago started the same way here in Lebanon. Lebanon's different. Whatever you know about using evidence in policymaking, it's different here in Lebanon. But one of the things is people say research evidence isn't valued in this country. Well, that's true in a lot of countries. And it's true in many Canadian provinces, and until about 5 years ago, it was very true of my home province of Ontario. But things change over time. You can convince policymakers and stakeholders to put value on the use of research evidence. Our colleagues in Kenya, Tanzania, Uganda did that. They drew up case studies of where research made the difference between policy or program success and failure, and they convinced senior policymakers to do a better job. Andy Oxman and I went and interviewed all the senior players at the World Health Organization in Geneva, and they all admitted that they were working in the old model of what we call GOBSAT. When they develop guidelines, they use GOBSAT. Good old boys sitting around the table. Very little use of evidence, just a lot of old white men sitting around the table saying, this is what I think everyone in the world should do. But on the day that the paper came out in The Lancet, Margaret Chan released a press statement saying they were overhauling their guidance development process. And WHO has upped its game, and they're working with people like Ellie and others to make sure that they have a more rigorous process. So you can embarrass people into doing that type of thing. We also work with journalists to highlight statements that are and aren't based on the best available evidence. We have a partnership with a journalist at Canada's largest news magazine every week. She's on leave right now, but she finds statements made by political and other leaders and then looks to see whether there's any evidence backing up their claim. And if there is, she celebrates it. If there isn't, she gives them a very rough time. And that has led her to be called into the minister's office. And the question has been, how do I avoid being in your column in future? K2P is going to be working in this area. In fact, as you heard, there's a workshop going on right now with journalists, a 3-hour workshop. Another challenge is research isn't relevant. Fadi Al-Jardali, who runs the Knowledge to Policy Center, known around the world as being someone who's done a lot of innovative work in this area of priority setting. Very few countries in the world do this well. but we need to be talking to the people who are making tough decisions and asking them what are the issues that are likely to be on your agenda 2 to 5 years out, and for those we can put in place new data collection systems, we can conduct new primary research. But tell us what the issues are that you think you're going to have to make a call on within 6 to 15 months. And there we can work with Spark here at AUB and other people to produce systematic reviews. But we also need to know what are your requirements in a couple of weeks, a couple of months, and there we can work with K2P to produce evidence briefs, or what they call here, what are they called? No, K2P policy briefs. Yeah. And so we have some examples. Listening for Direction in Canada tries to do the longer term stuff. 3IE tries to do this for systematic reviews. Evidence-informed policy networks that are operating in 44 countries around the world, some of them do it. Cameroon would be a good example. But that's certainly something that we can do. It doesn't mean all research needs to be ready for action, but a fraction of it, at least at a given time, needs to be trying to address the needs of people in the system. Another piece of this is research isn't easy to use, and there's a couple of parts to this. So one is research isn't communicated effectively. You pick up newspapers and it's this study shows that, this study shows something else, very little effort to start with the challenge that people are dealing with and work backwards to find out what does the evidence tell us about the problem and its causes, what does it tell us about options, what does it tell us about implementation considerations. There's now teams in 11 African countries, for example, part of a VIPNet that do this on a regular basis. Whatever the big issue of the day is in Uganda, Ethiopia, Mozambique, a VIPNet immediately puts together a policy brief. The Knowledge to Policy Center is now doing that as well. We do it at the McMaster Health Forum. So instead of trying to package our research, we start with the issue that people in the system are struggling with, and we work backwards to pull together the relevant evidence. Another thing, I work at one of the universities in Canada that has the worst reputation for this. My dean loves our medical school's name to be in the press. And so he has a media office whose job is to find out whether any of us are going to be publishing an article in a high-profile journal, JAMA, New England Journal, The Lancet. And if we are, they do a huge push. That might be the 14th study on a topic, and no one in the media office ever says, have you put this in the context of a systematic review? And if it's a study that deals with a little part of the problem, no one ever says, well, where's the evidence about the other aspects of the problem? Where's the evidence about what we're going to do about it? Where's the evidence about the implementation piece? So many of us face these crazy incentives to be marketing our single studies when we should probably be putting them in the context of a review and making clear to people that we're only answering a little bit of the series of questions that a good policymaker might ask. So much of the research done in most countries is down here. Very helpful. 20 years from now, it could transform society. A bunch of us do applied research. A very small group of people do systematic reviews. And until K2P came up, you would be very hard-pressed in any Eastern Mediterranean country to find anyone doing evidence briefs or policy briefs. Another piece of this is evidence isn't available when policymakers need it in a form that they can use. That's been one of the huge changes in the last 5 years. So nowadays, there's no excuse. If your question is about clinical programs and services or about drugs, you can, between the Cochrane Library with their effectiveness reviews and Hedges or the validated search strategies built into PubMed, you can quickly pull up the best available science. If your question is more public health, what can we do to improve the health of groups and populations? You can now go to Health Evidence, every systematic review of effects in the world about public health interventions in one place, and you can go to the PubMed Hedges to get the other types of evidence. And if your question is how do we strengthen health systems or how do we get cost-effective programs, services, and drugs, every systematic review in the world, we're just shy of 4,000, is sitting in health systems evidence. Every economic evaluation in the world about health systems and implementation sitting in health systems evidence, just over 2,000 of them. So policymakers used to say, well, this isn't feasible. We have to answer 10, 15, 20 questions if we're going to do a good job on policy. And that means searching many databases and so on. But now they can pull the evidence up in a very, very quick period of time. We also see people staffing rapid response units. So the Regional East African Community Health Policy Initiative in Uganda was the first to do it. Unbelievably well received by policymakers. So Burkina Faso adopted it, Cameroon adopted it, we adopted it at McMaster. And our approach in Canada is we provide a rapid response within 3, 10, or 30 business days. So you have a big question about the health system, and you tell us how long you have, and we'll pull together the best available evidence in that time. And the K2P Center is going to be doing the same here. Provide training and tools for policymakers and stakeholders about how to find and use evidence. So this isn't about training them in how to do critical appraisal, that kind of stuff. It's training them to understand how to systematically ask questions that can be answered by research evidence and know where to go to find that. Knowledge to Policy Center has been doing that for the last 2 days here. We do it through our Health Systems Learning Initiative, and with Andy Oxman and others, we wrote the support tools, so 18 of them that help people with particular parts of that job. So all of that, trying to make evidence available when people need it and in a form that they can use. Next one, policymakers lack mechanisms to prompt them to use research in policy making. This is one of the few instances where I can say my home province of Ontario has done something innovative. They knew that the rush of their world was such that people were constantly throwing stuff up to senior decision makers without looking for evidence. So they said, okay, we're going to put in a simple prompt. You can no longer go up to the Ministry Management Committee or to Cabinet without filling out a very simple one-page form that says how you found and used evidence about the problem, options, implementation, and you have to say which databases you searched. So if you can't fill that out, or you ticked the wrong database, you ticked the Cochrane Library when your question was about health system, it's sent back. It's a very simple mechanism to prompt people to have to document how they found and used evidence. And then finally, policymakers lack forums where challenges can be worked through with stakeholders and researchers. This is where the deliberative dialogues, that's what they call them in the social science literature. We call them stakeholder dialogues. Here at the K2P Center, they call them policy dialogues. Evidence briefs are the jumping off point. So everyone gets the brief in advance. No one can make factually incorrect statements. No one can assert that we have definitive proof that results-based financing is going to have hugely positive outcomes on the system. Everyone has the evidence brief, and then you get all the key players around the table that are then talking through, well, what is really the problem and its causes in our country? Which options make sense for us? Which implementation considerations are going to be the most important? And what are going to be the next steps for key groups? We're also now doing them with citizens because we find that we can get the heads of civil society groups to come to stakeholder dialogues, but a person off the street finds it very hard to sit around the table with the head of the medical association, senior public servants, and so on. So we now have panels that are exclusively comprised of citizens. Socioeconomically diverse, ethno-culturally diverse, and so on, sitting around the table, also informed by a brief, but a brief written in plain language, so they too can contribute their views and experiences on a major public policy issue. So any questions about those options? So the big problem in this area for us is we need to be evaluating these rigorously. We cannot say these are effective. We have lots of data and research evidence suggesting they're highly valued. We have evidence suggesting the briefs and the dialogues translate into strong intentions to act using the theory of planned behavior, but we can't make definitive statements yet about effectiveness. But that's the portfolio. K2P Center doing many of those, us doing many of them, and evaluating them as we go. Any questions about the options that people are experimenting with in this area? Okay, so let's move on to what's needed to do the work. So I just have a few more minutes. So one piece of this is the knowledge. People need to know the questions to ask about a problem options implementation. They need to know the types of evidence. So they need to know if their question is about benefits. In the jargon of our world, that's effectiveness studies. They need to know what sources they need to go to for that type of evidence. So again, if it's health systems and your question's about effectiveness, you would go to health systems evidence. They need to know what things like an AmStar score means, so they know whether it's a high or a low quality review. And then if you're really lucky, there'll be a support summary that's been written that has a grade assessment, but not enough of those have been done so far. But as more get done, they'd also need to know what grade means. They need to know the questions to ask about local applicability, because you could have a fantastic systematic review, but none of the studies were done in Lebanon or even in the Eastern Mediterranean region. So how do you think through how applicable are these findings to Lebanon? And they need to know the difference between knowing what other countries are doing, which we call jurisdictional scans, compared to knowing the results of research conducted in other countries, which we think of as research evidence. Policymakers very, very focused on what other people are doing. What's the UK doing for us? We're very focused on what's the United States doing. But who cares what they're doing? The question is, do we have any evidence that what they're doing is actually achieving good outcomes at reasonable cost? And that takes research evidence. It doesn't just take phoning up or reading in a newspaper that they're doing it. We need to know what kind of outcomes it's achieving and at what cost. People also need to have a good set of attitudes about this, that this is iterative work, that we need to work through problem options implementation in a very context-specific way. So what a policy brief in Lebanon on an issue is going to look like is going to be very different from what it would look like for another country. They need to be systematic and transparent. We think about all that all the time when we think about research, but we also need to be systematic and transparent in our policy work. We need to be thinking about finding and using the best available evidence in the time we have, and we need to be thinking about looking first for that perfect match and then looking more broadly for research that might help us think differently about an issue. And then finally, there's a set of skills for the folks who actually do the work. So the folks in the K2P Center need to know how to do very particular things. So let me just give you an example with the clarifying the problem, because this is where I think we often go wrong. And as I said before, a lot of people say policymaking is 90% battles about the problem and its causes. So this is an example that I've shown a couple of times over the last 2 days. This whole issue of low rates of childhood immunization. Why do we care about it? Well, because it's unbelievable that nowadays we see the emergence of these preventable childhood illnesses. What's the indicator of the problem? Program coverage rates dropping, and in countries like mine where we have this crazy fascination with celebrities, we have celebrities out there making completely unfounded statements about how immunizations can cause other types of illnesses. But we need health system thinkers who can point out to people that this is great, the epidemiologists can help us with that, but maybe the cause of the problem is fragmented accountability. You can't point to GPs or anyone in the system who is accountable for the immunization rate. Even in a rich country like us, we have this unbelievably crazy system where refugees have to pay out of pocket for immunizations, free for Canadians, not for refugees. In our country, many children aren't registered with a primary care team that can proactively reach them, and we have a lot of parents who aren't aware of the new immunization schedule. If we get the problem wrong, we're going to get the solutions wrong. And data and evidence can help us understand which of these are the real causes of the problem. And too often in policy, we skip to the action, and we miss the part about looking for the data and evidence about the problem. And there's very particular places we can go for that evidence. Then if we move on to options, in a particular country, you might say, well, based on our understanding of the problem, these are the ways that we think we should be moving forward. We could change a governance arrangement, establish accountability among primary care practices. We could change a financial arrangement and get rid of this nonsense that we charge people for something as critical as childhood immunization. Or we could undertake an implementation strategy with the mass media campaign. All very good ideas, but the question is there any evidence to suggest that the benefits of these are going to outweigh the harms and justify the costs, and that they're going to be well accepted by citizens? Again, want very particular types of evidence. We want benefits questions to be answered through effectiveness studies, harms by a range of different studies. We want cost-effectiveness analyses if they exist. We want to see the process evaluations so we know how and why they work in case we're going to adapt them. We want to know if there are any acceptability studies out there. And all of that can now be done incredibly efficiently with one-stop shops. And then finally on to barriers. You might run into challenges at any of those different levels, and depending on the answer, then we need to know which implementation strategy should we be looking at. And then it would be on to the same questions about benefits, harms, and so on. So this is tractable stuff. People can do it fairly efficiently. If they're well trained, they can know where to go, get the evidence, pull it in, look at the quality rating, and make determinations that help people to make better decisions. So let me end with the priorities for action. So this is to try and get you talking about what could be done in Lebanon. So I don't believe that Lebanon is that different from the many other countries that we work in. There's certainly things that are unique here, but here's some things that I would say would make a big difference. Contribute to making the Knowledge to Policy Center the region's most effective knowledge broker. There are now shops like K2P, the McMaster Health Forum, in a number of countries around the world, but to our understanding, there is no other one in the Eastern Mediterranean region other than the nascent K2P Center. So what that means is helping them prepare evidence briefs, maybe in future one day preparing citizen briefs, convening what you call here policy dialogues, maybe in the future convening citizen panels. Preparing those rapid syntheses, promoting the one-stop shops, providing the training like you've been doing over the last couple of days. So that's one thing. Second thing, advocate that policymakers and stakeholders make Lebanon the region's leader in evidence-informed policymaking. So in Ontario, 5 years ago, we were an embarrassment globally. One of the wealthiest provinces in one of the wealthiest countries, and we systematically ignored evidence every time the big decisions came up. And what made the difference was a very well-placed senior policymaker who said this is unacceptable. The role of civil servants, not politicians, the role of civil servants is to bring high-quality information to politicians to help them make tough decisions. And once they make those decisions, whether we like them or not, to work out how best to implement those decisions to achieve the biggest impacts for the least amount of money. And both of those can be informed by evidence. So what that person did was send strong signals that using research evidence is a high priority. They put in place a performance requirement for staff. Very simple. Anyone involved in policy development once a year has to document how they found and used research evidence in just one example of a policy process. They put in place an internal rapid response service. So in addition to a K2P center, there was an internal service that could do the same thing because there's times where the issue is so confidential that they can't share it with outside groups. And they established that internal requirement with the research evidence tool that you can't take anything up unless you can document that you found and used evidence. And this changed the landscape completely. We could have been sitting there at the McMaster Health Forum doing what we thought was great work for 50 years and had little to no impact. What had to change was the demand side. Hugely different climate. 5 years later, it's a very, very different jurisdiction. And then maybe the piece that would be a little bit more controversial is, can we not at universities move beyond only assessing people based on their research and teaching? So absolutely, it's critical that we pull in peer-reviewed grants and we write peer-reviewed publications. It's also critical that we teach the next generation of scholars in a great way. But we also need to figure out how do we reward people for taking the time to go out and do all of this other stuff, because it will lead to better policy and ultimately lead to better health for the citizens of our country. And the other thing is remove the incentives to publicize the results of single studies without clear justifications. Maybe AUB isn't like this. I work, as I said before, in the worst medical school, I think on the planet, certainly in Canada, in terms of doing this. And I face this incentive. Whenever I go and see my dean, his first question is, why are you never in the news? Like, well, what's with that? And it's just a crazy incentive. Anyway, those are my 3 priorities for action. You've got this nascent K2P center that I think has unbelievably great potential. You can find allies in government who can figure out how to institutionalize these ways of doing things. And the university, I think, can also start to make it easier for academics to keep doing their great research, keep doing their great teaching, but also try and maximize their impacts on policy. Resources, we have a summary sheet, which those of you who are at the workshop have seen before. It's sitting on the Health Systems Evidence webpage if you want to see the support tools. Unfortunately, they're not in Arabic. Health Systems Evidence, by the way, though, is in English, French, Arabic, and 3 other languages. And then Health Systems Evidence, there's a 4-pager. So the website is in Arabic, and the summary sheet then is in Arabic, but not the other pieces. So that's the quick run through. Lots of time for questions. Questions or comments? Yep.
Hello, I'm Ala Alouh. I'm a public health student here at the faculty. And in the past year, I've worked with Dr. Khalid Jardali, worked on stuff related to K2P and evidence-informed policymaking. I'm a proponent of evidence-informed policymaking. I did my internship in the Ministry of Public Health, so I know kind of what I'm talking about. So I just have one thing. I did a research project where I interviewed journalists, researchers, and policymakers. And I just want to stress what you said. The fact that researchers only work for promotion through peer-reviewed journals is a big deal. It limits researchers' time. It limits their incentive to actually do something other than research. So I totally agree. Then again, my graduation project is really, I'm doing a policy brief on financing primary care. I just want to ask a question related to technical barriers that we, as people trying to do briefs, face. Especially here in Lebanon, you talked a lot about really finding the real cause of the problem. And if there is no evidence, if there are no indicators, it is very hard. So oftentimes, we just have to conceptualize, talk to people, and it's our opinion, which I think really defies the idea of being objective. Because I'm doing something about primary care, a lot of the evidence is about hospitals. So I kind of extrapolate, but it's still not the same. So there's that. And then when it comes to implementation barriers, implementation considerations, needless to say, a lot of the evidence comes from high-income countries. And yes, there isn't really contextualized evidence. It's more like what I know about the country, what I know about the context, and what I think is locally applicable or not. It becomes a judgment issue for the researcher or for the person doing the brief, which I think can be a great limitation to our work. So yeah, I'm just sharing this as an experience, and if you have any ideas of how we can face that.
Well, the local applicability question, we can at least ask the questions systematically about the issues that might make something more or less locally applicable. So I think we can systematize it a little bit, but you're right, it's still a judgment call at the end of the day. How likely would it be that we would get similar findings in Lebanon compared to the studies where it was done? But that's for that instrumental use of research. But even when we can't use it instrumentally, we can use it to change how we think about issues. On the issue of, that there's often not local data, local studies, it's an issue in every country. And, in Canada, we write briefs all the time. I think we're now on our 32nd or 33rd. There's always times, even in Canada, where we don't have data. So we're left saying, well, let's look at some other high-income countries and say, well, we think it might fall within this range. So we try our best to do it. But at the opposite extreme, one of the most active platforms to support evidence-informed policy, VIPNet Burkina Faso, 3rd poorest country in the world, they pull off evidence briefs. And there's times where, they have to rely on WHO estimates or they have to rely on data from other countries. It's always the best data that we have. And one of the things that these briefs can do, in addition to informing policy, is pointing to gaps in our data collection systems and any weaknesses in our research infrastructure so that 5-10 years from now, the data can be stronger and we have more primary studies. I'm speaking to the converted in the front row. It's all the K2P folks.
No, the faculty is converted.
Okay,
I think that's why
okay.
they're not asking.
Okay.
First, I just want to comment on what you just said about the ability of your brief to point out gaps in the literature. I also conducted a policy brief as my graduation project on coordination mechanisms for Syrian refugee health response in Lebanon. And what I found was a lack of systematic reviews on those issues when I was looking for options.
Yep.
Although this is a very old issue, refugees, and it's very important and is increasingly important, researchers have not really went in that direction, looking systematically at the evidence and the effectiveness and saying, well, this works here and that's why.
Yep.
Also, another question. I think in Lebanon, if we really want to work on evidence-informed policymaking, we need to be able to convince policymakers that this is important.
he should be held accountable by the population, by the public. They need to ask him the question, how are you making these decisions? That's the only way they care. Because in the end, they want to be elected. How do we create this culture of accountability? How do we get people to understand what research evidence is, what evidence-informed policymaking is?
Yeah, the first thing I think was more of a comment, so I won't comment on that, but the second one is a big challenge. I mean, people do say we need to be raising the bar in terms of scientific literacy so the general public is more aware, but I think that's always going to be so tough. I mean, the general public has 50 million things that they're much more preoccupied by, and what are the chances that they're ever going to focus on this, and are they really going to be comfortable saying that evidence should triumph even when it affects me and my family in an adverse way? So it's kind of tough. I think we have to play to the sense of accountability within senior public servants and within people in stakeholder groups to say, at the end of the day, why are we here? Well, we're here because we're trying to have an impact on the health of people. And if that's what we're trying to do, then one input into our decision making absolutely has to be evidence. And if you're a public servant, as I said before, not the politicians that are elected, but if you're a public servant, your job at the end of the day, many people will say, is to try and get the best information in front of them, knowing that politics is going to drive a lot of decision making, but at least trying to get the evidence. And no matter what they decide, there's always good and bad ways of implementing it in ways that can either help or hinder our efforts to move things forward. So I think we just have to try to really focus on the public servants and on the stakeholder groups to get them to have that accountability. I don't know if we're ever going to get there with the general public. Yeah.
I have a comment maybe or question. All these centers and all these initiatives start from the researcher side. So the
Start from the what?
Starts from the researcher side,
Right.
from the academic part. And we are trying to preach or to extend to the policymakers and to the government and the public administration. What I feel is that because it's coming in, for example, the K2P, all these centers are based within the institutions, are based on your experience or based on what you know about globally. Are such centers, have such centers been established within the public sector to start with, rather than established within the academic and then stretching out? So instead of initiating the questions, the issues from the academia, this has been initiated from the public sector, in the public sector. And why I'm thinking about this, because my interest is in aging and older people. I've always thought that it's, and I've been trying to preach the Ministry of Social Affairs regarding the importance of taking the aging population as a major issue in Lebanon, and they haven't been, aware about it. They became aware about it when they had established the National Commission of Aging, and part of the mandate of the National Commission of Aging is to do research. So it's only this research which has been initiated by the National Commission or within the public sector that it reached to the heart and to the minds of the minister.
Absolutely.
It's not me as an academician trying to impose on the public sector or on these ministers or people involved in the policy making about the issue of aging. It's only when it was initiated within the public sector that it became an issue of priority.
Absolutely. You and I met in Riyadh, no? Yes. Okay. So yes, I mean, so we have examples of VIPNets that are based in government. So a VIPNet Burkina Faso, for example, it's a unit within the government. So there, the idea from the very beginning, the people who pushed for it were public servants working in the ministry, and they decided the best place was in the ministry. And then we have examples like us in the K2P Center that are located in universities, but in my home province of Ontario, we're outside, and they have an equivalent unit inside that does the same thing, but does it from the inside. So they have a rapid response unit, all this stuff. We trained them, but they have the inside track. And increasingly, they're the ones that are having a big impact because they're able to push and push and push inside, whereas when we're outside, we're seen as an interest group. We're trying to push from the outside, but they kind of think, well, some days you seem like you're just like all these other interest groups. So if the country is wealthy enough and there's enough highly skilled individuals to have two centers, then it might make sense to have one in both. But certainly in Burkina, they went with inside. Other jurisdictions have gone with outside. We have a 44-country study going on right now to try and understand why did people make those decisions, and does it seem to have an impact on their influence in terms of government decision making, but for now we don't have an answer to the question of when would you choose it to be inside versus outside, but I take your point.
I have one comment.
Yep.
Also. So where do you advise this kind of a hub to be placed? I mean, it should be at the governmental level. It's not placed within ministries, right? I mean, where is this?
Well,
how is the structure?
it depends what its portfolio is. So the one in Burkina Faso is only tackling health, so it's located within the Ministry of Health. But if it was providing a general support function, then it might be reporting to Cabinet Office. So it depends what its remit is. Yeah.
Thank you for the wonderful presentation and for challenging us to think about how to address the challenges in Lebanon. So you mentioned the importance of rewarding faculty for engaging in supporting policy making. So you do this at McMaster, and are there ways to standardize this kind of contribution for the purposes of promotion and for the purpose, so I think in the Faculty of Medicine we have some frameworks for even financial compensation. So are there any standardized way that we could potentially use?
Yeah, no, I wish. I mean, McMaster's innovative with problem-based learning and all kinds of stuff, but we're retrograde on many issues. We get no credit for it. So your close collaborator and my department chair every year gets a spreadsheet where I get so many points for a Lancet publication and so many for this, and I don't get points for these types of activities, or if I do, it's because I put them under other headings. But we do have examples. The University of Toronto's Department of Psychiatry and Behavioral Sciences, it's very clear how you get credit for this annually and how you use it to build a case for promotion and tenure. So we do have a few working examples. I have not been successful in importing it to McMaster. If you do it here, we'd love to see it because we think we need more examples of this. You're volunteering to do it, Iman?
We've developed some kind of a spreadsheet like this where we actually have also points for what we refer to as the outreach and practice.
Super.
We still give more points and more weight to the research side.
Sure. Okay.
Because the issue is not the evaluation on an annual basis. The professor is caught at the point of promotion when, at least in this university, it's a university-wide decision. And hence the focus to standardize across all faculties, they sort of revert to back to the fact that research is the most important thing, and then everything else becomes icing on the cake. The problem that if you've done only that and you don't have the research, that's where the problem is. But I don't think it's only an administrative bureaucratic issue. I think the problem is, and you mentioned that at the end of the day, the policymaker is using different sources of information and evidences to decide. And one of them is the scientific evidence that you are providing, or others, or systematic reviews like Eli and colleagues will do. But then that person in that position is actually using so many other sources to the extent that I'm not sure whether you can link a systematic review or the effort of one faculty member with the final problem.
Right.
So perhaps the evaluation at this point in time is only process oriented. So this is part of the process, but not the impact. With same with research, but where in research we talk about impact factor. And we say that if you're publishing in this high impact factor journal, it weighs more than publishing in another journal. You can say the same thing for these things, except a good example was Riemann and Asch's work. Where is Riemann? Riemann and Asch, Dr. Asch, Riemann's work on tobacco control was easy to trace, because you say she did this research, she has a connection, and there's a tobacco control law. Even if you say she contributed 10% to all of this effort, but at least you can say she was definitely very active in pushing that law. I'm not sure we can sort of do the same with others, but I think it's something that definitely schools like ours, public health, maybe less so in medicine, but more again, medicine can move that. I think in urban design and architecture, there's a lot of push towards protecting heritage buildings, new designs, sort of, again, how do we measure the activism or the bringing the evidence to the table?
Yeah. But I agree with you. I think that nowadays we're kind of stuck with process measures, and then the only other way that we've seen it done is with impact statements. So in our home province, the Ministry of Health, because it funds some of our activities, they want us every year to tell 1 to 3 very compelling stories of impact, and they're short. But they find that that's unbelievably powerful with the politicians. So the one that is due, I guess, for us today, I'm working on it, is one example that we used was that we were asked one day by the number 2 person in the ministry to take on this very challenging issue that the government needed to make a decision on. Within 7 weeks, we wrote the brief, we convened the stakeholder dialogue, we wrote the dialogue summary, we briefed the senior players, it went up to cabinet 3 days later, and then a decision was reached. And you can see very clearly all of these very specific things that happen. So we can describe that process, and maybe we only have one of those every 3 years, maybe it's every 5, maybe it's every 6 months, but sometimes we need to be telling those stories as true stories. And it makes all of us as researchers a bit uncomfortable because it's anecdotal, but those impact stories I think helpfully complement the process stuff.
Thanks very much. It was really stimulating.
I had a question that was prompted by something I read yesterday in the paper, which was a study that's just come out in the U.S. that showed that everyone always knows, which is that policymaking is completely dominated by the rich. So I looked at 30 years of policymaking, and it showed that issues that were promoted by people who were less well off, disproportionately did not get into the policy arena, whereas those promoted by the better off. And of course, it's what we all know, but it was documented. So my question about this is, because of course we as researchers are also from the upper echelons of society, so where does the equity aspect come in here? I mean, are there any examples of where there's actually been a sort of equity screen or filter to some of these issues? Because we all know that some of the issues that we might choose to promote we come with our own agenda as well.
So great question. I can't point to 2 examples of where equity lens drove the choice of topics, but I can say that many groups that produce policy briefs use a similar approach to what we use, which is that we pick 1 to 2 groups that we call in English the canaries in the coal mine, the groups that we're kind of worried about. They could be a linguistic minority, they could be a low socioeconomic status group, it could be people living with 2 or 3 or more discordant health conditions, whoever we're most worried about. And throughout the evidence brief, in each of the problem, options, implementation section, we first go over the evidence in general, and then we say, but what do we know about that group? Are the causes of the problem perhaps different for them? Are the benefits and harms of the intervention different from them? So that's one way it gets incorporated. Second way is we explicitly take an equity lens on our choice of key informants that inform the terms of reference for the brief and for the dialogue invitees. So we're specifically saying on this issue, if we're worried about these groups, let's get those voices to the table. So for the stakeholder dialogues or the policy dialogues, they're typically the head of civil society groups that try to address their needs. For the citizen panels, they're actually people from those communities. And for policymakers, that's been hugely helpful to be able to hear the issues directly from people so that they're actually much more attentive to the equity issues. So those are 2 ways that we've tried to build it into briefs and to dialogues, but I think it's a big issue and we need to think about it all the way across. And also, we've never tackled it meaningfully at the priority setting stage for the topics we take on. So we're responding to what policymakers and stakeholders tell us the issues are, but as you say, those are largely elites, so we might not be getting at some of the true issues that are bothering many groups.
Thank you. So if there are no further questions, I would like to thank Dr. Lavis for this valuable talk, and thank you for attending.
Thanks very much. You're very welcome.